Hello everyone, welcome to HIM 216. This will be our second lecture for Chapter 2. In your textbook, please turn to page 35. This information that we're about to go over is some absolutely critical, essential information. It is sometimes the most difficult to understand and the most difficult to actually apply. So the first thing we want to talk about is when we are coding, and your book tells you this on page 35, that it's the responsibility of a coder to extract from that health record the diagnoses for which the patient's being treated and the procedures that have been performed. When we extract this information, we refer to this process as abstracting. So when you see a job for a coder abstractor, it means not only are you going through the process of assigning the appropriate code, but then you will be extracting that information and typically entering it into a database to complete the abstracting process. And when we code an abstract, we define and pull out the admitting diagnosis, the principal diagnosis, any secondary diagnoses, the principal procedure, any secondary procedures. If patients have procedures, many times we're abstracting the date of those procedures, the surgeon for those procedures. Some facilities want coders to abstract the anesthesiologist for that procedure. There are some basic things that all facilities abstract, and those are typically the elements that go on the billing form. And then some organizations have additional things they want coders to pull out for quality reasons or other monitoring processes. Now, also on the bottom of page 35, it tells you that the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. And you will often hear me say the condition determined to have after study to have occasioned the admission. So that's the principal diagnosis. Some of the things that I think are important, well, the principal diagnosis is the most important thing that you need to understand as a coder and be able to apply. If I were taking this course and I were studying, I would have note cards. Get recipe cards, index cards, and there are certain terms that you need to consistently remember. There will be certain coding guidelines that are problematic that you need to remember. This definition of principal diagnosis, secondary diagnosis, principal procedure, and secondary procedure are items that I would put on note cards. Not only to study with, but so that when I'm coding, I can have those beside me so I can go back and read them and remind me of what I'm looking for in that documentation that I am reviewing. Your book tells you that this definition for principal diagnosis is one of, if not the most important concept that a coder has to understand and apply. Because the assignment of the principal diagnosis and the principal procedure very often determine the reimbursement for the facility, this is a critical area. It has the potential for fraud and for abuse. If you have coders that can't code, it is a huge risk and liability for your organization. So you have to have coders that know how to code. And if they can't review a record and determine a principal diagnosis and a principal procedure, you have major problems in your organization. So if we look on Your book also tells you that this principal diagnosis as well as the procedure determine the assignment of the Medicare severity diagnosis-related group, which we call the MS-DRG, or many times we just refer to it as the DRG. Now that MS-DRG determines reimbursement, and this is a complex process. You'll become more familiar with it when you go through the 3M training, and then also you'll take a reimbursement course, and we'll do work with it a good deal there, but we'll also you'll have lectures where we have examples of using the grouper. And when you go through the 3M training, the 3M is made up of a number of different types of software. If you're accessing that software through your eHIM Virtual Lab access, the software is extremely expensive. There's no way the college could afford that software. As students, you couldn't afford to pay a fee to cover it if it weren't part of the virtual lab. It includes the integrated codebook, which is the e-codebook that we will use extensively for ICD-10-CM and PCS. It includes the reference package. It includes an encoder, which we won't even try to use until next semester. If you don't know basic coded guidelines, you can't use an encoder. And then it also includes the grouper software, which gives us reimbursement for Medicare in both the inpatient and the outpatient setting. It also includes standalone groupers and CPT code finders. So it is really phenomenal and amazing software. But the grouper portion of that software, when you put your codes into the grouper, then it assigns the DRG, and we'll spend a lot of time looking at that. The other thing that it's very important to understand is that physicians may not even be aware of the definition of a principal diagnosis or a principal procedure or how it's applied. So this is really a function of the coder. And of course, how successful you are may depend entirely on physician documentation. So we're going to talk about the query process towards the end of this chapter as well. And of course, here's the definition of the principal diagnosis: the condition after study that occasioned the admission of that patient to the hospital for care. And of course, it's the key for most federal, if not all federal, reimbursement. Now, a procedure is like surgery. So patients have a diagnosis. So I have a diagnosis of acute appendicitis. And then I come to the hospital and they take out my appendix. They do an appendectomy. The acute appendicitis is my principal diagnosis. My principal procedure is the appendectomy. So the principal procedure is that procedure that is performed for definitive treatment, and diagnostic procedures that are performed for both principal and secondary diagnoses. So you sequence the procedures based on the one that is most related to the principal diagnosis. Procedures performed for definitive treatment and diagnostic procedures that are performed for both principal diagnosis and secondary diagnoses are also coded. And then you sequence the procedures based on which one is the definitive treatment and most related to the principal procedure. Let's look at on page 35. We have an example at the bottom of the page. This patient comes to the emergency room with a cough and a fever. After the chest x-ray is reviewed, it's determined that the patient has pneumonia. So the principal diagnosis is pneumonia. They had a cough, they have a fever. Those are symptoms, and they are symptoms of pneumonia. They are integral to pneumonia. They are not coded separately. The condition that brought this patient to the hospital is the pneumonia, so it's sequenced as a principal diagnosis. The chest x-ray is a procedure, but it doesn't meet the definition of a significant procedure. We'll look at that in just a minute. This chest x-ray is not coded by HIM coding professionals. It is coded, but it's coded by the charge master and not by the coder. All right, let's look on page 36. In this example, a patient presents to the emergency room with acute abdominal pain. The patient's evaluated and they're taken to OR for an appendectomy, and the path shows that the patient has acute appendicitis, and this is confirmed by the physician in the discharge summary. So the abdominal pain here is not the principal diagnosis. It's not even coded. Patients with acute appendicitis have abdominal pain, so it's integral to the appendicitis, so it is not coded. The acute appendicitis is the principal diagnosis code, and the appendectomy will be the principal procedure code here. Your book tells you that sometimes that principal diagnosis is not really easy to identify. And so here is another example. Let's talk about this one. So this patient is admitted for coronary artery bypass surgery. Okay, we refer to this procedure commonly as a CABG. It's called, you may have heard it called heart bypass surgery. So this patient has come in and they have obstruction of their coronary arteries to the point that they are in danger of having a heart attack, or they may have had a heart attack or a myocardial infarction. And the purpose of this procedure is to use other venous material to bypass the obstruction. And that's why it's called coronary artery bypasses. They use material to actually bypass the obstruction in those coronary arteries. So, and the diagnosis that this patient has, that's the coronary artery bypass surgery, that's the procedure. But they're doing this because the patient has coronary artery disease, which is the obstruction of those arteries. So they do the surgery and it's successful. But on the 4th postoperative day, so the 4th day after surgery, this patient develops pneumonia. The pneumonia is severe. The patient goes into respiratory failure. They have to be intubated. That means they're put on a respirator, they're put on a breathing machine, and they're taken to the intensive care unit. That patient stays in the intensive care unit for 10 days because they cannot wean the patient off the ventilator. So the patient is on a ventilator. They try to take them off the ventilator, but they can't do it because the patient will not breathe on their own. So then this patient has to undergo a tracheostomy, which means they put a breathing tube in their trachea, looks like it's in their throat, it's in their trachea, and then they send the patient to a rehab facility. There is a lot going on here. This patient had a lot of things that happened to them, but it really doesn't matter what happened to them because the condition determined after study to have occasioned the admission is the coronary artery disease. That is the principal diagnosis. The procedure that was performed was the coronary artery bypass graft, and that is the principal procedure. Now, are we going to code the fact that they had pneumonia? Absolutely. Are we going to code the fact that they had respiratory failure? Absolutely. Those are both secondary diagnoses that we will code. The patient was also intubated. That's a procedure. We will code that. And they were placed on a ventilator, and we will code the fact that they were on a ventilator. That is also a procedure code. And then they had a tracheostomy performed, and we'll also code the fact that the patient had a tracheostomy. So a lot of things going on there, but in the end, the reason that they came into the hospital, the condition that occasioned that admission was coronary artery disease, and the principal procedure is the CABG, the bypass grafting, to treat the coronary artery disease. Now let's talk about the principal procedure. Again, Okay. Now, there may be cases when there is a procedure performed, but it was not related to the principal diagnoses. When this happens, we are going to sequence the procedure that was performed for definitive treatment of the secondary diagnosis as the principal procedure, since there are no procedures that are related to the principal diagnosis. Every now and then it happens. Let's say that a patient comes in and they have pneumonia, and while they're in the hospital, they slip and fall and break their hip. Well, there's no procedure that was performed for the principal diagnosis, which is pneumonia, but we have a secondary diagnosis of a fractured hip, and the patient had a hip replacement for that fractured hip. And so that's actually, we will code the pneumonia as the principal because that's the condition that occasioned the admission. We also will code the fact that they had the fractured hip because they had that. They fell and broke their hip, and then our procedure has to be the definitive procedure related to that secondary diagnosis. In your book on page 2, it talks about selection of the principal procedure. And it tells you that these instructions should be applied for the selection of the principal procedure, and also for clarification if you have more than one procedure performed. And so it tells you if the procedure was performed for definitive treatment of both the principal and a secondary if the procedures were performed for both a principal diagnosis and a secondary diagnosis, you're going to sequence the procedure that was the definitive treatment that is most related to the principal diagnosis as the principal procedure. Okay, so then you're going to say, well, what might be an example of that? So let's say that our patient actually came in and they had lung cancer, and they had a lobe of their lung removed. And when they were up ambulating this patient, the patient fell and they broke their hip, and so then they had to have a hip replacement. The condition that occasioned the admission was the lung cancer, and the procedure related, the definitive procedure for that lung cancer was the resection of a lobe of the lung. That would be the principal procedure. We would also code as a secondary diagnosis the fractured hip, and then as a secondary procedure the replacement of that hip. Number 2, procedure performed for definitive treatment and diagnostic procedures performed for both principal diagnosis and secondary diagnosis. Okay, so let's say that we have a patient who is admitted with a breast mass. They do a biopsy, they determine that the patient has breast cancer, and then they do a mastectomy. Our principal diagnosis here is going to be the mastectomy, because that is the condition that occasioned the admission. They came in, yes, the admitting diagnosis was breast mass, but when they biopsied it, they found that that mass was actually cancer. So the cancer is the principal diagnosis. Now, the definitive procedure for that cancer is the mastectomy. So that is sequenced first as the principal procedure. The patient also had a biopsy. That was the diagnostic procedure. We are going to code that breast biopsy, but it will be a secondary procedure, not a principal procedure. It doesn't matter if it was done first and then they did the mastectomy. The definitive procedure is the mastectomy. The breast biopsy was diagnostic. They took out a sample of a mass, or they took out a mass, they looked at it and said, this is breast cancer. That was a diagnostic procedure. And because she had breast cancer, the definitive procedure is the mastectomy, or the removal of the breast. Number 3. A diagnostic procedure was performed for the principal diagnosis and a procedure is performed for definitive treatment of a secondary diagnosis. So we're going to sequence that diagnostic procedure as the principal procedure, since that is the procedure most related to the principal diagnosis and it takes precedence. So I'm going to come up with an example for you that I'm not sure would really happen in real life. But let's say that a patient comes in and they have a breast mass and they do a breast biopsy and it's negative. And while the patient's there, they also do a colonoscopy. And when they're doing the colonoscopy, they accidentally perforate the colon, and so the patient has to have a colon resection. Now, the breast mass would be the principal diagnosis. The breast biopsy would be the principal procedure. And the colon, let's say that they were doing a colonoscopy because they were looking for diverticulitis, and when they did the colon resection, all they found was diverticulosis. And at that time, they accidentally cut the colon and they had to do a colon resection. Well, in that instance, the diverticulosis would be a secondary diagnosis and the colon resection would be a secondary procedure. Now, certainly a colon resection is a much bigger, much more extensive procedure than a breast biopsy. But in this instance, the intent when that patient came in was not to do a colon resection. That just kind of accidentally happened. They accidentally damaged the colon to the point that they had to do a colon resection. And then finally, the fourth example is no procedures were performed related to the principal diagnosis, but procedures were performed for definitive treatment or diagnostic procedures for a secondary diagnosis. And so in this instance, those secondary procedures are coded. There's no procedure for the principal diagnosis, but we do have a secondary diagnosis and a procedure was performed. So this is kind of a little tricky and it's a little wordy, and for me, if I don't actually have an example to look at, to me it can be pretty tricky. So just look at this carefully and understand that as you go through your coding education, this will begin to make more sense. And honestly, a lot of these rules and guidelines that we're covering will begin to make much more sense as we go through different examples. Now, UHDDS requires that we report other diagnoses that have significance for that specific hospital encounter, and I want you to carefully look at this definition of a reportable diagnosis. It's at the bottom of page 36. Conditions that coexist at the time of admission or develop subsequently or affect the treatment received and the length of stay. If it's a diagnosis that's related to an earlier episode of care that has no bearing on the current hospital stay, they're not coded. So if my patient is coming in for a breast biopsy, and when she was 6, she had pneumonia, that's totally unrelated to this admission. I'm not going to code that. But if my patient is coming in for a breast biopsy in her right breast, and she previously had cancer in her left breast and had already had a mastectomy, that personal history of breast cancer is very important, and I would code it because it does have a bearing on this case. Now, your book goes on to tell you that other diagnoses are maybe conditions that require clinical evaluation, therapeutic treatment, or a diagnostic procedure, or they extend the length of stay, or they increase nursing care and or monitoring. These can be things like if a patient's a diabetic. They're not coming in specifically for the treatment of their diabetes, but because they have it, it has to be monitored. They have to be evaluated. So you're going to code it. It's a chronic condition, and we actually do code chronic conditions. COPD, congestive heart failure, diabetes, hypertension. Those are some of the very common conditions that patients have, and the fact that they have them requires that they be monitored and evaluated. Clinical evaluation on page 37. During the stay, the hospital develops a low sodium. So the physician notes this condition. He documents the lab values. That's clinical evaluation. Because the patient had it, they had to continue to monitor it. Therapeutic treatment. This can be medications, it can be physical therapy, and surgery is a form of a therapeutic treatment. So in this example, the physician documents that in the patient's past medical history, they had a history of a seizure disorder. They're on Dilantin. Dilantin is for seizures. So the fact that this patient's being treated for a seizure disorder and they're on that medication means that this is a reportable secondary diagnosis. Sometimes physicians will list conditions in the patient's past medical history for which they are currently being treated. So as a coder, you have to be familiar with medications and the conditions they treat. If the physician documents that the patient has a past history of high blood pressure and they're on a blood pressure medication, they don't have a past history of it. They have it. So in those instances, we will actually code those. Now, this lecture is getting a little long, so I am going to actually stop here and pick up here when we come back. For this lecture, in exercise 2.2 on page 39, I want you to answer question number 1 and question number 3. And so that will conclude this second lecture for chapter 2.